Welcome everyone to a journey into the intricate world of anti-LRP4 antibody myasthenia. This rare autoimmune neuromuscular disorder can significantly impact daily life, and in this video we'll unravel its mysteries, exploring its origins, symptoms, diagnosis, and current treatment strategies. The precise cause of anti-LRP4 antibody myasthenia remains somewhat elusive, but it's understood to be an autoimmune disorder. This means the body's immune system, which normally protects against foreign invaders like bacteria and viruses, mistakenly attacks its own healthy tissues. In this specific type of myasthenia, the target is a protein called low-density lipoprotein receptor-related protein 4, or LRP4, located at the neuromuscular junction. To understand anti-LRP4 antibody myasthenia, we need to visualize the neuromuscular junction. This is the crucial site where nerve cells communicate with muscle cells. When a nerve impulse arrives, it triggers the release of a neurotransmitter called acetylcholine. Acetylcholine then binds to acetylcholine receptors on the muscle cell, initiating muscle contraction. However, in anti-LRP4 antibody myasthenia, antibodies attack LRP4. This disrupts the formation and maintenance of the neuromuscular junction, impairing the efficient transmission of nerve signals and leading to muscle weakness. The exact mechanism by which LRP4 antibodies interfere with neuromuscular junction function is still being actively researched. Anti-LRP4 antibody myasthenia is considered a relatively rare condition. While precise numbers are difficult to ascertain, it's less common than the more frequently diagnosed acetylcholine receptor antibody, positive myasthenia gravis. It's crucial to remember that anyone can potentially develop anti-LRP4 antibody myasthenia, regardless of age or background. However, more research is needed to fully understand its prevalence and distribution across different populations. The hallmark of anti-LRP4 antibody myasthenia is muscle weakness that worsens with activity and improves with rest. This weakness can affect various muscle groups, including the eyes, leading to drooping eyelids, ptosis, and double vision diplopia. Facial muscles may be affected, causing difficulty with chewing, swallowing, and speaking. Limb weakness can make it challenging to perform everyday tasks. Breathing difficulties can also occur in severe cases, although this is less common than in acetylcholine receptor antibody, positive myasthenia. Diagnosing an LRP4 antibody myasthenia requires a multifaceted approach. The diagnostic process typically begins with a thorough neurological examination to assess muscle strength and reflexes. Blood tests are crucial to detect the presence of anti-LRP4 antibodies. Electrophysiological studies, such as repetitive nerve stimulation and single-fiber electromyography (SFMG), can help evaluate neuromuscular transmission. Imaging studies, like MRI or CT scans of the chest, may be performed to rule out other potential causes of muscle weakness. A tensilon or edrophonium test, where a short-acting cholinesterase inhibitor is administered, can temporarily improve muscle strength, supporting the diagnosis. While all forms of myasthenia gravis share the core feature of muscle weakness, they can be further classified based on the specific antibodies involved. Anti-LRP4 antibody myasthenia represents a distinct subtype, separate from acetylcholine receptor antibody, positive, and MuSK antibody, positive myasthenia gravis. Understanding these distinctions is critical for tailoring treatment strategies. The primary goal of treatment is to improve muscle strength and reduce symptoms. Medications, such as cholinesterase inhibitors, can help increase the availability of acetylcholine at the neuromuscular junction. Immunosuppressive therapies, including corticosteroids, azathioprine, mycophenolate mofetil, and cyclosporine, are used to suppress the immune system and reduce antibody production. In severe cases, intravenous immunoglobulin IVIG or plasma exchange (PLEX) may be used to provide temporary relief by removing or neutralizing the harmful antibodies. Thymectomy, surgical removal of the thymus gland, may be considered in some patients, though its role in anti-LRP4 antibody myasthenia is still under investigation. Symptomatic treatments, such as physical therapy, occupational therapy, and speech therapy, can help improve function and quality of life. Currently, there are no proven methods to prevent anti-LRP4 antibody myasthenia. Because it is an autoimmune condition, the focus remains on early diagnosis and effective management of symptoms. The prognosis for individuals with anti-LRP4 antibody myasthenia varies. While some individuals experience mild symptoms that are well controlled with medication, others may have more severe disease requiring more aggressive treatment. Fortunately, most people with anti-LRP4 antibody myasthenia can lead relatively normal lives with appropriate management. Recent research efforts are focused on gaining a deeper understanding of the disease mechanisms, identifying potential therapeutic targets, and developing more effective and targeted treatments. This includes exploring novel immunosuppressive agents and strategies to selectively deplete or suppress LRP4-specific B cells. Clinical trials are ongoing to evaluate the safety and efficacy of new therapies, Continued research offers hope for improved outcomes and a better quality of life for those living with anti-LRP4 antibody myasthenia.